All right, so today our topic is diabetes. I don't have any financial interests in diabetes. This is to get us started so we can make sure everyone's working on this poll everywhere. Basically, at the top of your phone, you type 37607, and then you text George Ford 678. That will allow you to then enter the poll for all the rest of the polls we'll have in the slideshow. And once you've texted George 678, it should welcome you, and then you can put in an answer A, B, C, or D, and then it should pop up on the screen.
So you do that again. You call.
So you text
text
3 to the number 37607, and then the actual text you just write George Ford 678, then send that text, and then it should make you part of the poll. And you go from there. All right, we've got at least one person has got on the poll.
That's me, I think.
Try myself.
While we're waiting, could we get an email address for Dr. Wallace?
Dr. Wallace, could you share your email address?
Sure, it's Phoebe, Febe.Wallace, Wallace, at CherokeeHealth.com.
Thank you.
Okay. Has everyone been successful? Looks like we a couple answers. Right. Anyone not successful getting on there?
I'm still working on getting it to work. I'm driving. Well, riding, actually.
Don't do that.
Okay, well,
I'm driving. Still working out here.
okay, well, drive safely. You know.
Yeah, I'm riding. I'm not driving.
Okay. All right. So the answer to this was C, which obviously the majority of you have chosen 1 in 400. Okay, good. That was more of a test to make sure that was working. So, type 1 diabetes is the major diabetes of childhood. Obviously, we're also now seeing more pre-diabetes and some type 2 diabetes. It does affect 1 in 400 children. The peak incidence is in puberty. There's also kind of a pre-tween peak as well, in the kind of 7 to 9 range. We're also seeing a little more, the incidence is increasing in children in the 2 to 4 range, who are often not thought of, and we're not sure why we're getting an increase in that younger group. It is an autoimmune disease. It's important to remember that it does put you at higher risk for both celiac and Hashimoto's or thyroid disease. People will often ask practitioners what the risk of getting type 1 is. For the sibling, it's about 5%. If they were an identical twin, it's 13 to 33%. You can see from that identical twin disparity between 13 and 33 that it's not a heavily genetic disease, that it's a predisposition, and that other factors are in play. Caucasians are affected more than other ethnic groups. And here we just have kind of a normal islet cell, as well as insulitis. It is T cells basically drive the B lymphocytes to make antibodies to the islet. And as you can see, it's kind of an angry group of people there in the red there. We often get kind of questions about the onset of type 1 diabetes and that process. It is very unpredictable. It can occur very acutely over weeks, usually over months, sometimes over extended periods of time. But as you can see on this graph here, there's quite a bit of you can kind of level out and then improve a little bit, then fall, and then, so there's different rates of change. Basically, once you've lost about 80% of your cells and have fallen below that threshold, that's when diabetes starts to become clinically evident, usually with some polydipsia, polyuria, and then some weight loss. Again, especially in our younger kids, this is often missed. So we'll talk a little bit more about that. And then, you know, most patients are going to want to know, like, how did I get type 1 diabetes? Why did this happen? Again, we do know there's some genetics, the HLA, DR3 and DR4, as well as some other genetic subtypes that have been shown to have a genetic predisposition, but you can inherit those genes and not get type 1 diabetes. You may get a different autoimmune disease or none at all. So we do know that other factors are in play. The farther north you go, the more type 1 diabetes there is. So we think there may be a vitamin D or other factor in play. Viruses have been studied and tried to be implicated, and there are certain viruses that seem to put a child at higher risk of getting type 1, but again, hasn't really been nailed down. People also looked at food and food introduction and cow's milk. People have also looked at toxins. The short answer is we're not sure, but we do know there's additional factors involved. Often there's a preceding history of some major stress, whether it's an illness, a divorce, a broken bone, but then there's plenty of histories where you also get nothing like that. This is just a nice curve that kind of just shows you that how type 1 diabetes is increasing. It's varied a little bit. I think right now it's been more at a 3%, but anywhere between 2 to 5%, tracking data from the 1980s onward, and from Finland going all the way back to 1950. As you can see, those northern nations, Finland and Sweden, have much higher rates than other areas. You see the US sample coming out of Colorado, and then slightly below that, you have Germany. And this is really true of most autoimmune diseases, much more prevalent in industrial countries than non-industrial countries. Okay. Well, before we jump to that, any questions about kind of basics of type 1 diabetes?
Is there any benefit of drawing insulin levels if you think someone's having some signs? I mean, I wouldn't know how to even interpret anything if they're becoming more glucose intolerant. Is there any sign of that? Obviously in type 2, there's signs of glucose intolerance, but type 1, I don't know.
Yeah, so for type 1 diabetes, you know, people might consider insulin or C-peptide levels. They're really not going to be horribly useful unless you've been getting them maybe serially. But, you know, most people who present in the early stages of type 1 diabetes still do have that initial, you know, 20% or so of cells still there. So a lot of them actually have normal insulin levels and normal C-peptide levels. Even several months, especially during the honeymoon phase, a lot of people will still have C-peptides that don't fall below the quote-unquote normal threshold. It used to be a lot of insurances request C-peptide to prove that a person had diabetes. That created all kinds of problems for people who were new onsets who haven't reached that point in their disease path. So generally speaking, insulin levels are also just not really worth getting in general, unless you're really trying to figure out, does this person have type 1 and type 2, and you're looking to see if they actually make a lot of insulin. And the prior recommendations to get insulin levels in kids you think have type 2 diabetes have been rescinded. And so regular insulin levels are not recommended in type 2 diabetics. You should use your clinical judgment, glucoses, acanthosis nigricans, other signs. But there's really nothing to do with a high insulin level. That's the other part of it.
Right.
And it proves what you already know.
Thanks.
Yeah. Okay, let's try our poll again and see if folks can answer this question. Basically, one of these patients fits the criteria of having diabetes. A has a 2-hour postprandial of 188. B has an A1C of 6.2. C has a 1-hour postprandial of 148. D has a fasting of 128. And 2-hour postprandial blood sugar of 178. Put lots of 8s in there. I thought that would be fun. Okay. Well, it looks like we're getting a fairly good consensus for D, which is the correct answer. So any fasting blood sugar over 126 qualifies as diabetes. Any oral glucose tolerance test blood sugar over 200 would qualify as diabetes. And A1C greater than 6.5 would also qualify as diabetes. Obviously, in the type 2 group, we see a lot of kids who are going to fall in that 5.7 to 6.4 range. If we get enough time, we can talk a little bit more about prediabetes. But I found as I was preparing the slideshow, type 1 kind of is probably going to take most of our time. Okay, so now we have a patient in the office, comes in, is complaining of drinking too much, and eating too much, and maybe some weight loss. You pick up on this and you find some glucosuria, but no ketones at this point. You get a point of care blood sugar at that point, and it's 413. So now, watch at the following is the most appropriate initial management. Let's see, here's the poll. So A is send a referral to endocrinology for outpatient appointment as soon as possible and have the patient record fasting blood sugars. B, begin Lantus based on body weight and sliding scale for blood sugars greater than 150 and have patient record fasting blood sugars. C, begin diabetic diet, consider start of Lantus and send for outpatient referral. Have patient checking fasting blood sugars. And D, send patient to the emergency room and notify pediatric endocrinology office. I don't know if there's a way to tell how many people have actually responded. Has everyone had a chance to respond? Looks like we're having, at least so far, complete consensus on D. So yes, D is the right answer. How often does A happen? About 20% of the time. So we've actually gone through stacks of referrals and found, A1C 10.8, drink plenty of water, follow up with endocrinology. So that would not be appropriate for a variety of reasons. Even though this patient in this scenario doesn't have ketones yet, that could tip at any moment. And they really are going to need full education, which we can't really provide on an outpatient basis at this time. So a question?
Take you back downstairs for some more MRI.
Could you say that one more time? I couldn't quite hear you. We're having a problem with someone's speaker. Anyway, if you get it working, hopefully I can answer your question, but right now we're unable to hear your question.
They can raise their hand and, they can send a chat at the bottom.
Okay.
If the speaker isn't working, they can type in a chat down there. Just hit that little chat thing on the bottom of the screen, just to let people know.
Excellent. Thank you, Dr. Wood. So yes, if you're having any problems with the audio, please feel free to text and I'll answer. I think most people know these general symptoms. Other symptoms that people often complain of are some blurry vision. You can sometimes smell the ketones on the breath. It smells like acetone. Certainly, if you're seeing Kussmaul breathing, you know you're already dealing with some degree of DKA. You know, if they're vomiting and nauseous, they should be getting to the emergency room as soon as possible. Okay. So we kind of already went over this question, thanks to Dr. Wood. This question was kind of looking at, should we measure antibodies, insulin levels, and C-peptide levels? Kind of already give away the insulin levels and C-peptides completed component. It looks like we got people going with false. Basically, so kind of as I stated a little bit earlier, definitely we do not routinely get antibodies on a person who's clearly presenting with classic type 1 diabetes. I've already kind of gone over the limited usefulness of insulin and C-peptide levels. The one caveat, and could have still been potentially a correct answer, was C. Of course, I put all patients, so that throws C out a little bit. But if you did have a patient who, let's say they're presenting and they're obese, they have some acanthosis, you might wonder whether they're truly presenting with type 1. Their A1C may not be as elevated as typical. So in those instances, I will measure fasting, and always should be fasting. We all make insulin when we eat, so fasting, insulin, and C-peptide levels, and in situations where there's significant diagnostic uncertainty, we will send antibodies as well. The only problem with antibodies is even in type 2 diabetes, approximately 15 to 25% of people will eventually have or will have at presentation some antibodies, but they're still considered type 2. All right, so we get a lot of questions about diet and type 1 diabetes. So this question is kind of getting at that. Patients with type 1 diabetes need to ensure that they eat a diabetic diet with specific carbohydrate targets for breakfast, lunch, and dinner that are age appropriate. So we have our answers there. The first one's true, a diabetic diet allows children with diabetes to take less insulin. False, a diabetic diet is too high in fat and protein for most children. True, a diabetic diet is ideal as long as the child is greater than 10 years old. D, false, a diabetic diet is not recommended. E, true, but the patient can sometimes enjoy higher carbohydrate meals at celebrations. Give a couple seconds for everyone to respond. All right, looks like we've got, at least right now, 33% going for D and 67% going for E, which is kind of what I was hoping to see, actually. So in general, a person with type 1 diabetes is not on a classic, what we would call a diabetic diet. When a patient's admitted to the Children's Hospital, they're admitted on a regular diet with carbohydrate counting. So in that classic sense, a diabetic diet is not used. However, most recent studies in the last year or two have shown that there is some benefit in setting specific carbohydrate targets for patients with type 1 diabetes based on their age, and especially if they're obese. So in other words, they're type 1, but with other factors that are causing increased insulin resistance. So especially in those patients, we will sometimes actually set carbohydrate targets, and we still allow for celebrations or eating out kind of thing. There's actually kind of growing non-consensus among pediatric endocrinologists in this area. Prior attempts to kind of limit carbohydrates were met with all kinds of problems in this population, including rebellion and sneaking food, and as well as eating disorders, which are much more prevalent in type 1 anyway. So because of that, the overall consensus is we still don't tell people they're on a diabetic diet. In general, a lot of kids, as long as they're well controlled and not overweight, we don't set specific carbohydrate targets. But for those in the category I mentioned who are kind of more overweight or obese, or other factors are in play, we will sometimes make those targets. So hopefully I haven't muddied the waters too much for you on that one. But in general, it's just good to remember that they're not on a classic diabetic diet. Any questions on that? Okay, great. So another question we get a lot about is the timing of insulin, especially in children. So this question is asking, prandial insulin should usually be given after meals for children with type 1 diabetes. And so we have A, usually true, B, usually false, C, based on family preference, D, it doesn't matter as long as the appropriate insulin dose is given for the meal, E, it doesn't matter as long as the child is on a diabetic diet. So far, okay, we're 50-50 right now. Okay, that's pretty good.
We have a D over here in the chat.
What's that?
We have a D in chat over here. So we got another one.
Oh, okay. A D in chat. Okay, so we've got also a D for it doesn't matter. Okay, great. Hopefully everyone had a chance to answer. Thanks for putting your D in there. So in general, prandial insulin should be given before meals for children with type 1 diabetes. Whenever there's a mismatch between insulin and food, you're allowing for an extreme kind of postprandial hyperglycemia. In fact, most recommendations and studies show that you really want to give insulin 10 to 15 minutes before you eat, as long as your blood sugar is in a stable range, in order to kind of match up your insulin and your food. That allows the insulin food to come up and down in a very uniform way, and you don't get those big postprandial excursions. When would we give children their insulin after they eat? Well, often very young children who are unreliable eaters, and so dosing pre-meal is kind of prohibitive. Children with special needs, autism, developmental delays, who again may be very untrustworthy in terms of actually committing to what they're going to eat. But we do try very hard in the very beginning, even in somewhat complex cases, to try to train both the child and families to give insulin before they eat. And in terms of D, it does end up mattering. It's much harder for us to get good glycemic control in those who give their insulin late. We also have a lot of teens who will forget to give their insulin if they give it after the meal. So that's kind of how we manage that. Any questions on that? Great. Another common question we get is timing of Lantus or Basaglar. Lantus and Basaglar are essentially the same thing. So once a day dosing for your background insulin. Usually people choose either to give that in the evening or the morning. Certainly in some cases we avoid morning if people are the kind of people who rush out in the morning and forget things. But it really doesn't matter which one you choose as long as a person's consistent. Levemir can be used for children, but it's generally not because it has to be a twice daily dosing. And we notice a lot of trends where people just tend to go either high or low when we try to use Levemir. So even at the Children's Hospital, we don't use Levemir as a basal insulin. Any questions about insulins or anything people want to know?
What was the second? I'm familiar with Lantus, but what was the second one you?
So this is actually an important one to know because a lot of people are getting switched to it. It's called Basaglar. It's from another company. It comes as an insulin pen only. So you can't get a syringe and needle for Basaglar. It can only be dosed also in whole units. So it's not ideal for younger children where you're trying to dose potentially 3.5 units of Lantus. But Basaglar is now formulary for a lot of insurance companies, and so patients are often forced to switch from Lantus to Basaglar. But in general, the results have been the same. That Basaglar is basically almost like a generic form made by another company of Lantus. So they basically pharmacodynamically are the same. And for that reason, they are very interchangeable. Often from year to year, the insurance will change which one it covers. We've had patients from Virginia that we've had to actually teach how to use Basaglar before they went home because we couldn't get them home on Lantus because it was no longer formulary. And then only if there's some sort of patient preference previously to use Levemir, and that's what they're used to, do we use Levemir. But in general, it's not used very often in type 1, in pediatrics anyway. It's fairly popular in type 2 diabetes. The other thing to know about insulins is if you have someone on an insulin pump, they're not going to have any Lantus, they're not going to have any Basaglar, so they're going to receive insulin depending on the pump at various intervals. Usually it's going to be programmed to give a certain rate every hour, but if you're on a Medtronic pump and you're in auto mode, that will be dynamically changed based on continuous glucose monitor readings every 5 minutes. If you're on a T-Slim pump, sometime in the next couple days, those individuals will also have kind of an artificial pancreas component where it will be changing the background insulin every couple minutes and looking into the future to actually prevent highs and lows. So just to know, pumps are evolving very quickly, changing very quickly. Most of our patients are also now on a continuous glucose monitor. Most use the Dexcom, which is continuous, can go to their phone, and then from that phone can be beamed to everyone else's phone, including parents or other caregivers. The Libre is used more in adult populations, but we do have a couple of people. But that one is a little patch that you can just scan your sugar basically, and it'll show you what it is, but not continuously report it. Although their next version of a Pediatric probably, or of that patch will. And in a pump, you're either going to have Humalog or Novolog, although just this last week, they even faster acting insulin, which is a Pediatric, was approved, but in adults and in very old adolescents. So probably won't be using it too much yet in pediatrics. But a Pediatric is a newer insulin. It has a much faster action, and so because of that, it's able to take the insulin and the food and match them up even closer together so that you have even less of a postprandial rise with eating. I'm pretty sure Dr. Los is using a Pediatric right now in his pump. We kind of gotten at some of this already, but 25% of patients presenting with type 1 diabetes now, or even more in certain areas, depending on incidence of obesity, are obese. So it does create some clinical uncertainty sometimes. Certainly one thing that really helps is type 1 kids definitely follow the honeymoon period very clearly, and type 2 kids often, if they really do need insulin, have a much higher degree of insulin resistance and a larger per kilo insulin dose. So now I was just going to kind of go through a couple things with diabetic ketoacidosis, but any questions again on insulin or insulin pumps?
are most, I mean, what percent of kids are on pumps versus injections nowadays?
Yeah, it's a good question. It does vary quite a bit by region. Part of it is a little bit of a socioeconomic indicator, since costs for pumps are somewhat prohibitive for some individuals. In our practice, I would say at least approaching 50%, maybe more, are now on an insulin pump. Continuous glucose monitors, probably closer to like 75% are on those now. And of course, with all these other new pumps, these continuous glucose monitors are increasingly being integrated with the pumps for these artificial pancreas capacities. Those pumps still can't deal with food, but they can deal with background insulin. So, you know, in general, the future of diabetes really is going to be insulin pumps, especially as these features are rolled out that merge the benefits of continuous glucose monitoring with background insulin delivery, and eventually algorithms that would even potentially account for food intake. So in the future, most of the patients you will meet with type 1 diabetes are going to have these technologies with them. So the more familiar you can be with them, the better, because they will definitely be coming into your practices wearing these technologies.
So that leaves me one question as a primary care provider.
Yeah.
If I'm seeing them maybe between your visits, or maybe they've missed your visits and now I'm seeing them, how can I tell how well they're doing? I can get a hemoglobin A1C, I guess, right? And then,
Yeah. Well, so everyone who uses a Dexcom app will usually have on their phone something called a Clarity app. And on that Clarity app, they can have a share code that's on there. And if they give you that share code, you just plug it into the Dexcom site, and you can download all their continuous readings over whatever period of time you'd like to look.
oh, wow.
Usually 2 weeks to a month. If you do 2 weeks, it'll usually give you about 4,000 readings. It will then chart for you all of their trends, their averages, their standard deviations, and then also it even reads out almost like an EKG, like this person has a pattern of nighttime hyperglycemia, this person, you know, whatever. And so if you can get a report like that, you on some level could act on that report, or even call us if you felt like a change was necessary. But certainly we do struggle sometimes, especially with some of our rural patients who may not be coming in. The current guidelines are for them to be seen every 3 months. We struggle with that both because people don't quite do that, and also we're so full now that from a practical standpoint, people often are getting pushed out beyond that 3 months. So if they're seeing you, especially if you can see they're having problems, feel free to look at that report. There are other ways to download pumps and other devices. Right now, usually you have to have an in-office
Right.
service. Right now it's called Gluco that most folks use. So without that service, you're kind of at a disadvantage. But because of some of these apps, like the one on the Dexcom, which a lot of people have Dexcom now for their continuous glucose monitoring, you can often get quite a bit of data and very quickly.
Would you mind sending out just a super brief, like, here's how you do this, to like on a sheet that would help inform us in primary care on?
Sure.
That would be really helpful.
I assume we could just use the same email list that you used, and we can send it out to folks. Okay. Yeah. But yeah, and we really, and in future things, I probably should do kind of a whole tutorial on these technologies, because it's important to kind of understand what might be going wrong, when to intervene, what can you do in your office, when do you need to call, when would you send them to the emergency room. Any other questions about insulin or insulin technology?
I have a question, but it's not necessarily about insulin or insulin technology. Because at the beginning, you were talking about diagnosis and lab values. And so, you know, we do point of care glucoses, fasting glucoses, and A1Cs. I've never done an oral glucose challenge. I mean, is there an indication for that? Is that something I should be doing as a primary care provider?
That's a really good question. The oral glucose tolerance test kind of fallen out of favor because of the advent of hemoglobin A1C as kind of a better indicator of what your overall average is. It is still sometimes done if you truly suspect type 2 diabetes, but generally, both from a practical standpoint, it's just not done very often. There are certain conditions where it is actually still considered the gold standard. Those would be ones where A1C is less accurate, such as cystic fibrosis. So in kids with cystic fibrosis related diabetes or concern for that form of diabetes, we actually do still perform glucose tolerance tests. And then sometimes we will do glucose tolerance tests in children, not for highs, but because they're having low blood sugars and we're trying to see how they respond to a glucose load. But otherwise, I would say you can rely pretty much on those fasting sugars and hemoglobin A1Cs for your patients. Does that answer your question, Dr. Hudson?
Yes, it does. Thank you very much.
Okay. Any other questions? I've got slides so we can keep talking, but I'm happy to just talk about whatever you would like to know. All right. So, DKA is certainly something that has come into a lot of PCP's offices lately, and they've called us or discussed it with the emergency room. Certainly, we start worrying about it. If blood sugars are staying consistently over 250, if you're on shots, a patient's told that if your blood sugar is 300 twice in a row, that you should automatically check for ketones, even if you're not feeling sick at that point. And certainly anytime a patient's feeling sick, they should always be checking for ketones, especially for obvious things like stomach pain, vomiting. If you're on a pump, the threshold is actually lower, and this is because of concern for pump failure. But if your blood sugar is 250 twice in a row and you're on an insulin pump, you're supposed to be checking your ketones. And of course, anytime they're sick. We do get a lot of pump failures. I would say we get at least 1 or 2 a month, generally speaking, coming into the pediatric intensive care unit. Often it's because their pump site has occluded or it's leaking. Sometimes patients will see their higher sugars and just keep trying to bolus through the pump. They're often late in checking the ketones. Often by the time they check them, they're very large and already starting to have symptoms of DKA. So if you have someone come into your office and they're on a pump and their sugars are running abnormally high, definitely have them check their ketones. We always teach them to clear those ketones with shots and not through the pump because of possible pump failure, and also because when you give a shot, you can see the insulin, you know what's going in, whereas with a pump, you cannot. And that's one of the chief disadvantages of insulin pump therapy. Just be watchful of that. So the other parts of our definition here, pH less than 7.3, bicarb less than 15, and usually they're going to have large ketonemia, ketonuria. Ketonuria is always going to lag behind a couple hours. So that's another thing to just remember. If they're already starting to feel sick, they may not have a lot of ketones if things have fallen apart very quickly, since there's a lag in the ketone results in urine compared to blood. Most places can't get a blood ketone measurement in a timely fashion. There's a couple places that can, but JCMC is not one of them. We rely a lot on the ketones in the urine and then presentation. Overall goals when someone comes in to us with DKA therapy is we want to correct dehydration generally over 48 hours, correct the acidosis, begin moving glucose towards near normal levels, By near normal, I mean hundreds usually, and often they'll get parked in the 150 to 250 range. Excuse me. And then, of course, we're trying to avoid complications of therapy. Okay, so we have a couple options. Someone's coming in, see you. I'm going to assume maybe your practice, because I know a lot of pediatric practices can bolus some fluids. So you're trying to tank them up potentially before going to the ED, or you're maybe sending them to the ED and giving advice. So we have a couple options. For moderate dehydration, give that 10 cc per kilo normal saline bolus. Do that over 30 minutes, reassess, and if necessary, give a repeat 10 cc per kilo bolus. B, moderate dehydration, give a 20 cc per kilo normal saline bolus over 30 minutes, followed by another 20 cc per kilo as necessary. C, severe dehydration, consider a 40 cc per kilo bolus over 1 hour, followed by another 20 cc per kilo bolus. And then D, severe dehydration, consider 10 cc per kilogram bolus if no cardiac instability, and then begin 1.5 maintenance fluid. I kind of let everyone, excuse me, log in.
To be here.
Okay. Hopefully, has everyone got a chance to put in their answer? Okay. Well, at least right now, it looks like we have a consensus for B. Did we get a text?
An A to B.
Oh, we have an A and a B text. Okay, so sounds like we got mostly B's with one A. Okay, so the correct answer, according to the international guidelines on the management of DKA, is A. B would be more appropriate if you thought someone was hemodynamically unstable or presenting with and you're trying to bolus fluid for sepsis or something. So the current recommendation actually is to try to go slow with fluids. Fluid overload and giving too much fluids is an independent risk factor for cerebral edema. Increases your risk. So we recommend starting with a 10 cc per kilo bolus, and then reassessing to see if they seem to need any more by looking at cap refill, mucous membranes, etc., vital signs. Certainly, if they're hemodynamically unstable, you could start with a 20 cc per kilo bolus, but for moderate dehydration, we would recommend 10. And generally, it's just best not to flood people with fluids. A lot of adult algorithms will just say give 2 liters of fluid now. So a lot of times we get teenagers getting overloaded with fluids before they're transferred. This is just kind of some basic things after you bolus and things are stable. If the potassium is less than 5, you can start adding in KCl and KPhos. And then generally a fluid rate of 1.5 maintenance is a pretty good rule of thumb. Unless you think they have severe dehydration, then you should try to calculate the percentage fluid loss, how much fluid's been given, and then try to replace that potentially more vigorously over a 48-hour period. Then various labs that will be drawn, and they're kept MPO, and of course neurochecks watching for cerebral edema. And then we have some just some slides again on moderate versus hemodynamically unstable. I think we kind of have gone through that. Generally, we do use a 2-bag method, which is, again, part of the international guidelines and is used pretty much universally in children's hospitals across the United States. In one bag, we have our D10 with electrolytes, and the other, we have a non-dextrose containing fluid with electrolytes. We also are using more of sodium acetate now to avoid hyperchloremic metabolic acidosis, which will sometimes cause the bicarb not to fully correct, even though a gap might be closed. And the D10 is usually introduced once blood sugars go under 300, and then increased to maintain the insulin drip. You need fuel, you need insulin, you need fluid. If you don't have those 3 components, you're not maintaining them, the acidosis will not resolve and could get worse. All right. So let's say someone comes to your PCP's office. They have symptoms of DKA. They've got large ketones, big glucosuria when you dip their urine. So you're sending them off to the ED, but they're asking you, should they give themselves an insulin bolus before they go? So what do you think? Should we give them an insulin bolus? True, false? I have no idea. See. Okay. Did we get any text answers on that one?
A B.
A B. Okay. All right. So it sounds like we have a text answer for B, and right now 67% B, 30% what? I have no idea. So the answer to this question would usually be false, and that's because we know that if you bolus insulin when someone's in DKA, if you're causing a major osmotic shift and causing a sugar to rapidly decline, you increase the risk again of cerebral edema. And so two big rules of thumb are never give too much fluids and avoid insulin boluses. So in general, you would not tell the patient to do that. If there were other, you could get into, like anything in medicine, there could be some extenuating circumstances like distance to an emergency room. If possible, try to discuss it with us before giving insulin. Important things to know on an insulin drip: it's a very short half-life, 4 to 5 minutes. So if you stop that, it stops real quick. So it's a great way to fix hypoglycemia really fast because it's going to be out of the system very quickly. Recommended dosing for insulin has kind of decreased to 0.05 units per kilo per hour, and then titrate up to 0.01 units per kilo per hour. And again, avoid bolusing insulin. All right, so which of these is not a risk factor for cerebral edema in a patient presenting in DKA? Insulin within the first hour of therapy, hydration greater than 50 cc's per kilo in the first 4 hours, persistent hyponatremia, persistent hypernatremia, initial serum blood sugar greater than 500. Get it.
1B.
Okay, 1B.
Well, B, but I'm guessing.
B, but I'm guessing. Okay. Okay, so I think we have persistent or hydration greater than 50 cc's per kilo in the first 4 hours so far, everybody. So that is a risk factor. So anytime you give more than 50 cc's per kilo, especially initially, you're increasing the risk of cerebral edema. The answer is actually persistent hypernatremia. And that's because hypernatremia on some level actually is protective of the brain. And so that would not be a risk factor for cerebral edema, but all the other things mentioned would be. The other big risk factor not listed there is if the child is less than 5, oh, it's on this slide, and a new diagnosis, they're 3 times the risk of having cerebral edema. So it needs to be very carefully considered in these young kids. And often part of that is late diagnosis. So 20% of people or children in DKA presenting with clinically evident cerebral edema do die. And another 20% have mild to severe neurological outcomes. They can get a thrombosis. And again, there's some risk factors. Obviously, if the DKA is more severe on presentation, potassium's higher on presentation, the baseline mental status is already abnormal on presentation. Those would all be risk factors. So clinical, if someone came into your office, either a new onset or someone with known diabetes and they're complaining of altered mental status or a sudden severe headache, you would definitely want to worry about cerebral edema. So another question we get a lot is, when should bicarbonate be given? And so we have several possible things. A, it's no longer recommended as is associated with increased risk of cerebral edema. Patients should instead receive a 20 cc per kilo bolus of normal saline. B, bicarbonate is considered if pH less than 7 after initial hydration and in cases when patient has acute mental status changes. C, bicarbonate can be considered if pH less than 7 after initial hydration and patient has cardiac instability. D, bicarbonate should be given if pH less than 7 after initial hydration and should be followed by a 10 cc per kilo bolus. Bicarbonate and mannitol should be given if pH less than 7 and patient has suspected cerebral edema or acute mental status changes.
I have no idea. Please educate me.
F. That was the text. Okay. Anyone want to hazard a guess? Okay, we've got at least someone or a couple people potentially on the. We have an A. Okay. All right. Oh, now we got a B. So we've got A, B, and E. Okay. All right. So this is probably one of my more tricky questions. Anyway, but basically bicarbonate is the highest risk thing you could give to put someone at risk for cerebral edema. It increases the risk 4 times what their underlying risk would be. And so we do only use it if pH is less than 7 and the patient has cardiac instability. So answer C was correct. Bicarbonate has no relationship to cerebral edema in the sense of treating it or treating an acute mental status change. Okay. So again, we only use this very, very sparingly, and there really needs to be concurrent cardiac instability if you're going to use it, because the downside is you really increase the risk of cerebral edema going on. Again, bolusing insulin within the first hour of therapy is a risk factor. Dropping that blood sugar too quickly is a risk factor. Too much hydration, like we already talked about. Okay, this is more of an adult chart of things to be worried about or kind of looking for criteria for cerebral edema. Just so you know, there are criteria kind of maybe less applicable to PCP, so I'm going to move forward. So now our poll is, which of the following is not an appropriate step in the treatment of cerebral edema? We have A, raise the head of the bed. B, give 3% normal saline at 5 cc's per kilo or mannitol at 0.5 to 1 gram per kilo. Increase fluid administration by 1/3 for C. D, consider head CT once the patient is stable. E, intubate if needed to protect airway but avoid hyperventilation. Anyone want to hazard a guess? We have a C. Okay. Anyone else? We have E. Okay. So the one on here that is incorrect is increasing the fluid administration. You would actually decrease the fluid administration by 1/3. Again, you're trying to avoid too many fluid shifts, osmolarity changes. You would raise the head of the bed. You would potentially either do either 3% or mannitol. You would consider head CT. Head CT is not that helpful for cerebral edema, but it would help with other potential complications such as a venous sinus thrombosis. And then E, you would actually avoid hypoventilation. That was a little bit tricky. So that's kind of what I just said. Those are kind of basics. If you were in an emergency setting and you thought a patient was coming into your office with cerebral edema. Again, CT is pretty unuseful as it relates to cerebral edema. You should treat if they meet the clinical criteria or you strongly suspect it. It's basically clinical diagnosis. Initial scans in people who are later confirmed to have cerebral edema are actually normal 40% of the time. So it shows you how not diagnostic that is. Certainly if they're altered or having problems, don't put them in the CT scanner. All right, and that was kind of my last slide. So hopefully that gave kind of a basic overview of type 1 diabetes, treatment, initial management, DKA, and avoiding cerebral edema. Any questions? Looks like some folks have moved on to clinic. Sarah or Sheila or ETSU Pediatrics, any questions?
No.
Okay.
No, it was a great thing. Good job.
Thank you.
Good job.
Any suggestions of things you'd like to see in future talks?
How about type 2 diabetes?
Say again?
Type 2 diabetes?
Type 2 diabetes. Yeah, I originally had type 2 diabetes in this talk and then realized it was way too long.
Yeah, this is really good about type 1.
Yeah. So yes, we can definitely do a talk that's more specific about type 2. Okay, well, thank you for those who were able to attend. It's great to have you.
Thank you.
Please come again next Thursday. We have another one at 12 o'clock.
Okay.
All right. Yeah, bring your friends. Invite your friends. All right, thank you.